Are you turning this over to me, Amy?
I was about to just introduce you real quick.
Okay,
Today's lecture is on risks and protections for patients with disabilities during the pandemic. And it's going to be presented by Dr. Robert Trug. Dr. Trug is the Francis Glessner Lee Professor of Medical Ethics, Anesthesia, and Pediatrics at Harvard Medical School, where he directs the Center for Bioethics. At Boston Children's Hospital, he is a senior attending physician in the Medical Surgical Intensive Care Unit, where he has practiced for more than 30 years. Dr. Trug, I'm going to turn it over to you.
All right, great. Thank you very much. It's a real honor to be here. I appreciate the opportunity to participate. I do want to say right from the beginning, I'm not an expert on issues of disabilities, and I'm really here as much as a learner as a participant in the discussion. My own experience in this area comes mostly through my work in the intensive care unit at Boston Children's Hospital. That has been a place where I've been able to see firsthand the real challenges that patients and families face in terms of the biases, the discrimination that occurs around patients and children with disabilities, and want to say that I'm here to explore those issues with you, particularly through the lens of the work that I've done with the Massachusetts Department of Public Health around crisis standards of care. Next slide. So for full disclosure, I do serve on data safety monitoring boards for research at a variety of pharmaceutical companies. I don't believe that any of those are going to impact my comments this morning. Next slide. The objective is to discuss the ethical considerations used to identify strategies for allocating supplies during a pandemic. Next. So, where did this start? Gosh, it's just been a little over a year ago, right? With the first cases reported from Wuhan, China. At the end of January, we did have a World Health emergency declared by WHO. And that was really the beginning of my involvement. Next slide. So by March 20th, the CDC saw that we were very likely going to have a shortage of medical supplies, and in particular ventilators. And so they issued a nationwide announcement that states should prepare for this and should develop allocation guidelines for ventilators. So that was on March 20th. Within a couple of days, our governor had appointed a task force. I was on that task force, and we worked truly day and night for about a week to come up with the first version of our crisis standards of care guidelines. Next slide. And to introduce this, let me explain what the difference is between normal standards of care and crisis standards of care. So normal standards of care, where the primary purpose of what we're doing is to maximize the health and welfare of individual patients. That changes in a really dramatic way when you have crisis standards of care invoked, because now the primary purpose is to maximize the health welfare of a population of patients as a whole. It's not a way that any of us are really used to thinking. Next slide. So our first guidelines were issued on April 7th. And I'm going to go over some of the key features of those. Next slide. So I want to say some of the challenges that we faced immediately and acknowledge those. So the first task force was small, and it absolutely lacked diversity. There were about 10 of us, and we were the 10 people that were probably the quickest to pull together on very short notice to come up with a document that the state really had no template for. And one of the big mistakes we made early on was incorporating this concept of life years saved into the algorithm. The idea was that for people who got a ventilator or were being considered for a ventilator, that we would ask how many years are they going to live if they survive this COVID infection. And the real problem there, of course, is that we know that for people with disabilities and for people from various socioeconomic groups, different racial categories, their life expectancy is shorter. And so this immediately was a problem in terms of unfair discrimination against all of those groups. And so it was quickly challenged by the HHS Office of Civil Rights. And by the way, this wasn't just Massachusetts. These were guidelines that were prevalent nationally. And so we quickly modified the guidelines. The revised versions came out on April 20th with further revisions, which I'll mention on October 20th, to eliminate this idea of life years saved and to focus only on very near-term mortality. I'll say more about that in a moment. Next slide. A couple of things we got right, I think, is that, first of all, the guidelines had no categorical exclusions. A number of states did have categorical exclusions. For example, patients with severe dementia, things like that, they wouldn't even be considered for a ventilator. So we completely eliminated all of those. Everybody has a chance. And then you get graded beyond that, determined by certain criteria. The guidelines were explicit to exclude consideration of disability, ability to pay or insurance status, perceived quality of life, past or future use of resources. So while these were explicitly stated, we do know, though, that those find backdoor ways of getting introduced through implicit bias. We did eliminate the life years saved, and with the most recent guidelines from October, substituted consideration of only very near-term mortality. That is, if you were expected to die within 1 year, you would get lower priority. And let me just say a word in defense of those, not definitive, but a word in defense, is that there are few patients with disabilities who are expected to die within the next year. And so the thought behind this was that by giving these patients lower priority, it would increase the resources available to everyone, including patients with disabilities. And so it was thought actually to be a pro-disability rights feature. Although, you know, it's arguable. And I'm not sure that even this will survive future iterations of guidelines that are written. Next slide. Some of the other features that were built into our guidelines is that we talked about the formation of triage teams that are separate from the bedside caregivers, both to separate the roles of, you know, on the one hand, giving the best care possible to patients. On the other hand, the triage team's role is to do what's best for the population. Separate objectives, separate roles. And also, it was to create the possibility for the triage teams to be blinded to any information that was not absolutely necessary to the decision making, to try to minimize the opportunity for implicit bias. Other features, that past or future use of resources should not be considered. This be particularly relevant to patients with disabilities. Also, that chronic mechanical ventilation is not relevant. One of the early concerns was, you know, a patient that would come in that was chronically ventilated, would it be possible that that ventilator would actually be taken away from that patient in order to give it to another person? So I want to say that, you know, the revisions of the guidelines have made it very clear that that would not be permissible. That if somebody came in with a ventilator, that's their ventilator, it will not be taken away. And then the final thing is that the Glasgow Coma Scale is a part of the allocation paradigm. The Glasgow Coma Scale looks at neurological functioning, three things: eye-opening, best response to a verbal command, and best response to a motor command. The guidelines now state that that score is only to be used with regards to acute neurological deterioration, which indicates acute brain injury, that scale would not be used for patients who have these deficits as a baseline. Next slide. I want to frame this discussion in terms of three broad themes, which I think come into play in most of the cases. So the first one being, well, let me just say what they are. How does good palliative care come into this? Number one. Number two, how do the crisis standards of care guidelines come into it? And then third, when do considerations of medical futility arise and how should they be handled? So at the beginning of the pandemic, there was a lot of discussion. that good palliative care requires that when any patient comes into the hospital, we think about what are their overall preferences. And for a number of patients, it may be the case that they would not want a ventilator, even if it turned out that they would be eligible to get one. And so, certainly this is a relevant factor, and I think reflects good palliative care. The question, as we'll see in the case that was reported at National Public Radio, is that I think sometimes this can be used inappropriately as a way of sort of, if you will, talking the patient out of their opportunity to have the benefit of a ventilator. Secondly, how do we decide when crisis standards of care guidelines are actually implemented? This has never been defined and still remains an issue. It appears that you can't invoke crisis standards of care without a determination by the governor. And to my knowledge, this has not yet been explicitly done. And in fact, Governor Cuomo was very clear that he was not invoking crisis standards of care, that everybody who needed a ventilator should get one, of course, ignoring the fact that that might not be possible. And so we've not yet worked out when are crisis of care standards authorized, when are they legal, and when do we think that clinicians have been adequately trained to use them responsibly. And then finally, an issue that has been going on for decades, of course, is how does medical futility play into this? When do we say that a treatment shouldn't be provided because it would be medically futile to do so? Next slide. And so I would encourage you to take a look at this piece that was done by National Public Radio. It was a case study of about a woman, 45 years old, with severe disabilities, who was cared for in a home. And she was brought to the hospital with an aspiration pneumonia. Her caregivers came with her to the emergency room, and they made it really clear to the treating physicians at the time that she had a POLST form for advanced medical directive, indicating that she wanted to be full code. And yet, right from the beginning, the clinicians were pressured into saying, really, it doesn't seem like that would be appropriate in this case. Wouldn't you agree to a DNR order, et cetera? And so the story spun out from there, and we could talk about the details. But I think you see the setup here. And next slide. And so, this sort of raises these three big themes. What's the role of reconsidering goals of care when a patient with a disability now presents with an acute deterioration that's going to require more treatment? Secondly, what are the role of the crisis standards of care guidelines in these decisions? I received several calls over the last several months from reporters where this exact situation was happening. Somebody came into the hospital and the crisis standards of care probably should have been utilized. They did not have enough ventilators. They had to pick between patients, but they didn't know how to do it. And so what ended up happening was families got pressured to institute DNR orders, which is a complete mix-up of two very separate issues. And I think was really wrong and really contributed to confusion. And then the third thing that came in was then, well, even if you don't agree to a DNR order, we really think that further treatment here would be futile. Well, there's a whole process for that was sort of being sidelined. And so I think that these three themes really contributed to a lot of confusion. Next slide. And so in sort of doing a little background reading here, I saw that actually some thought has been given, and there's a white paper from the National Council on Disabilities about how to think about medical futility in these situations. The recommendations, I think, are excellent. So let me just read them here. Hospitals and medical futilities should utilize an independent board to mediate and, if necessary, make medical futility decisions for patients deemed incompetent. And the board should be independent from the relevant facility and the providers, and should offer procedural due process protections, reflect diversity, and have at least one disability rights advocate as a member. And the decision should be appealable to a court of law. I think these are excellent recommendations, and to my knowledge, they don't exist anywhere. And we could talk more about that, but they are, I think, where we need to be going in terms of thinking about concept of medical futility in patients with disabilities. Last slide. And so some of the ways that I think we might frame the discussion going forward is, do the existing crisis standard of care guidelines adequately protect patients with disabilities? And if not, should they be eliminated? But if they are eliminated, I think we need to realize what that means. That means that patients would be treated solely on a first come, first served basis until resources are exhausted, and then they're not available for anyone. If we should keep these crisis standards of care, are there additional provisions that would improve protections for patients with disabilities? And then how can cases like the NPR example, or the one we're going to be discussing in a moment, be, well, the NPR case, be prevented, or coming up with best practices for cases like this going forward? So I'll stop there. Thanks.